or the quality of the process of shared decision making. If you look at several shared decision-making models, in general, there is consensus that there are about 3 or 4 steps. So let's focus on 4 steps for today. And then the first step would be to foster choice awareness, to indicate that there is more than one way forward, that we need to make a decision, and that whatever we do depends on what matters to the patient. So what do we know? It really depends on what kind of studies you follow, but about in about one third of encounters, clinicians indicate that there is more than one way forward. So clinicians try and foster choice awareness. We also notice that in a secondary analysis, if clinicians do foster choice awareness, it seems like patients are more involved in the other steps of shared decision making. It almost seems like indicating that whatever is coming, you will need to pay attention, because I would like to hear in the end what matters to you. It kind of helps people to stay active in that process of shared decision making. The second step of shared decision making is to discuss the possible options and the pros and cons of the options, the risks of those options. And we see a lot of variation in practice. So some patients receive a lot of information about the options, and other patients receive hardly any information. Interestingly is this finding by one of my colleagues, Ellen Engelhardt, who found that about 2/3 of the harms of treatment are actually presented after making a decision. And we can also see this in practice where, for example, doctors have a decisional conversation with a patient. They decide on what to do, and then they say, well, and now you go and see the nurse, and she will tell you everything about the pros and cons of the treatment. But the decision is already made. The third step of shared decision-making is to discuss the values and preferences of the patient. And in our own research, we found that about 1 of every 5 patients indicates what matters to them during the conversation with their clinician. When you look at values regarding pros and cons of options, we see that it's 1 of every 10 patients indicates that, I would like to prevent experiencing fecal incontinence or sexual dysfunction as a consequence of my treatment. And in most cases, this was at the initiative of the patient. So about 15% of the cases were prompted by the clinician. The last step of shared decision-making is to make a decision. And it really doesn't matter who makes that decision, as long as that decision is based on both the available evidence, the unique situation of the patient, and whatever matters to that patient. Andrew Yang, a colleague of ours, is now working on a study, and he found that in about 2/3 of encounters, the final decision includes at least one patient-centered rationale. So let's reframe. That means that in 1/3 of the encounters, there is no patient-centered rationale, and the final decision is at least voiced to be made based on evidence or the experience of the clinician. So this is all evaluating the process of shared decision-making, but if you evaluate the process, it's almost like shared decision-making is the goal in itself. The problem that shared decision-making is trying to solve is that there is no shared decision-making, which seems odd. So what other outcomes do we see in literature? We see that studies mainly focus, the number 1 outcome is patient knowledge. How knowledgeable are patients about the options, the pros and cons, but also about their risks? Do they have accurate risk perception? Then we see many studies focusing on decisional conflict, about whether patients are indecisive about what to do. And also about passiveness, which actually goes back to the process of shared decision-making again. Some other outcomes that we have been interested in are, for example, the unintended outcomes of shared decision-making. There seems to be a focus on everything that's positive to patients, to the system, to clinicians. But what is actually the work of shared decision-making? And what is the burden of shared decision-making? What do we know about that topic? We're currently working on a systematic review, and although we are still looking into the data, it seems like about 1/3 of the papers that we include have a mention of the work or the burden of shared decision-making as well. However, these comments are most often fleeting. So there are loose comments about the time it takes to be involved, or that it is burdensome to think about what matters to you. So far, at least as far as I know, we are not aware of any co-measurement. So if we evaluate shared decision-making, have we also assessed the degree of burden or work related to that involvement? In another systematic review, we looked at whether shared decision-making studies also focus on humanistic approaches to shared decision-making, so compassion and respect and empathy. And we found that about 1 in 10 papers have a single mention, at least one single mention of one of these aspects in their paper. This could be in the introduction, this could be in co-measurement, in interpreting the results, but it was in about 1 in 10 papers. In the same study, we also looked at what is actually evaluated when we use shared decision-making measures. And I cannot recall the exact number, but I think it was around 7% of all the items evaluating shared decision-making actually cover some kind of aspect related to humanistic approaches of care. But again, let's go back to what is that problem that shared decision-making is trying to fix. We have talked about a problem of shared decision-making not occurring in daily practice. We have talked about the problem of some of the outcomes. Patients are not knowledgeable. They do not know their risks. They are indecisive about what to do. Is that the problem? Well, I think that the problem is that 1 of every 5 patients indicate that they received care that did not fit well with them and their lives. 1 of every 5 patients. As Victor just mentioned, this was a reason for us to think about how we can collaborate on the topic of making care fit, on that collaboration between patients and clinicians and possibly loved ones, caregivers, in trying to design care plans that fit for each individual person. So we organized a 2-day meeting with an international interdisciplinary group of patients, caregivers, clinicians, designers, researchers, and policymakers. And after these 2 days, we wrote a manifesto on making care fit. It was published in BMJ EBM. I have a QR code here if you would like to look at it. The summary is that we believe that making care fit means that you maximally respond to the patient's unique situation and to their priorities, and that you minimally disrupt their lives, the loved ones, and their social networks. This is a collaborative process that involves at least a patient and at least 1 clinician, but could also involve a larger social network. And it is iterative. So it is an ongoing process, and you constantly need to reevaluate whether the care plan that we have still fits as the situation of the patient may have changed. So taking this manifesto as a starting point, we wanted to conduct a review looking at what is actually measured in studies focusing on patient-clinician collaboration. So a little bit broader than shared decision-making. And we found that 1/3 of all the measurement items actually evaluate the collaboration, the process itself. And by this, I mean that they do not look into whether we respond to the situation or the priorities, whether we minimally disrupt their lives, their loved ones, and their social networks, but they evaluate the manner or the content in which the patients and clinicians are working together. And interestingly, 1/4 of all items were evaluating the act of informing. And other aspects that may be relevant to making care fit, such as tailoring care, praising, caring in general, were less often present, or the least often present acts that we found. In our attempt to bridge the gap and to look at what is actually relevant when we evaluate efforts of making care fit, we wanted to look at the sensibility of care plans. So we asked patients how sensible their care plans were on a Likert scale, and we asked them to provide arguments for this sensibility. And we found that 1/3 of the patients indicated that decisions were sensible based on the act of working together. So they were not talking about what matters to them, about who they are, about their goals or their purposes, about characteristics of the treatments. But the argument why this treatment makes sense is because I collaborated with my clinician. Interestingly, we also found that how sensible the treatment plans are to patients does not relate to the extent to which patients were involved in their decision. And this involvement was observed by a third party and coded based on the videos of these conversations. So to go back to the manifesto, we have talked about what the problem is that shared decision-making is trying to fix. And we can see that there is a focus in literature on evaluating either the process or some kind of proxy outcome of shared decision-making. I think there's a lack of research looking at the goal of what shared decision-making is trying to achieve. In my view, that is trying to achieve that care plans fit for each individual person, that they make sense intellectually, emotionally, practically. We need to make sure that we maximally respond to patients' unique situation and their priorities, that we minimally disrupt their lives, their loves, and their social networks. I think these 2 days, this conference will be a unique opportunity to talk about these topics. We have a great program about minimally disruptive medicine. I would like to challenge you to think a little bit more about how we can maximally respond and support patients in their process, thinking about their unique situation and their priorities, and how we can make sure that a decision is not a one-time thing. It's something that we need to constantly reevaluate whether we're still in the right track. I look forward to having these conversations with you in the next 2 days. And if you have any questions, I'm very happy to take them at this point.